Thank you for your introduction, sir. And at the onset, I'd like to thank Dr. Balamurugan, sir, for giving me this opportunity. So today, my topic will be on Ozuldex. The first thing, Ozuldex is a dexamethasone sustained released implant. Okay, the size is 6 mm into 0.46 mm. It comes in a preloaded injector. The injector will be like a pen. It comes with a cap like this, right? So it's something like a pen and which has a button and an extra protecting device to prevent accidental injection. Okay, it's a biodegradable implant, so it biodegrades itself into lactic acid and glycolic acid. On hydrolysis yields to hydrogen and water. So the duration of the action which lasts up to 6 months. As you can see in the device in the upper end, it has a preloaded injector with a stainless steel injecting tip. That injecting tip is of 4 mm length. In that 4 mm length is the amount of the injecting area that enters in the eyeball, and it has a silicone stopper to prevent inadvertent extra length of the needle going inside the eyeball. Okay, and within that there is a 6 mm drug with a 0.46 mm diameter. So that was how the drug and the injector looked, and we come to the indications. As we had already seen in case of PST, we have a similar indications here. It's most commonly in coming to uveitis uveitis, it's intermediate uveitis, posterior uveitis, and pan-uveitis of non-infectious uveitis varieties. And other it was basically FDA approved for non-uveitis entity, mainly for CME associated with branch retinal vein occlusion and later for diabetic macular edema. And there's also off-label use along with cataract surgery for prophylaxis of Irving-Gass syndrome, that's post-cataract surgery, inflammation, and CME, and inflammatory CNVM, either standalone or in conjunction with other anti-VEGF injections. So before giving this injection, as Balamurugan sir was rightly telling, it's very important to give a detailed information to the patient and take an informed consent. Okay, it is not just a plain consent, it's a well-informed consent has to be taken with, ideally they say you should write everything right in front of patient and take your signature with the patient signature, but these days we usually have a printed consent form, but still it is our duty to explain the procedure as well as the expected outcome and probable complications that can happen with the procedure. So we'll have a small video on how the procedure, how the injection is being done.
Open the foil pouch and gently place the applicator on a sterile tray. Maintaining aseptic technique, carefully remove the cap from the applicator.
Sorry. Can you please play that video? Yeah, I can.
Open the foil pouch. Hold the applicator and...
Yeah, this was the thing happening. This is the stopper. So by mistake, if you press this button, the drug will get injected. To prevent that, you have a safety stopper.
Hold the applicator in one hand and pull the safety tab straight off the applicator. Do not twist or flex the tab. Holding the long axis of the applicator parallel to the limbus, engage the sclera at an oblique angle with the bevel of the needle up.
This is what JB sir was telling you. Should have a cotton tip applicator. It will help to anesthetize the localized area where you are injecting. Also, it will help to stabilize the glow. Or else, because we are doing this procedure in a topical anesthesia, there are chances that patient can keep moving the eyeball. But while injecting the drug, the eyeball should be very stable. This will also help in stabilizing the globe as well as anesthetizing the local area. Sorry.
Holding the long axis of the applicator parallel to the limbus, engage the sclera at an oblique angle with the bevel of the needle up, away from the sclera, to create a shelved scleral path. Advance the tip of the needle within the sclera for about 1 millimeter, parallel to the limbus. Then redirect towards the center of the eye and advance until penetration of the sclera is completed and the vitreous cavity is entered. The needle should not be advanced past the point where the sleeve touches the conjunctiva. Slowly depress the actuator button until an audible click is noted. Before withdrawing the applicator from the eye, make sure that the actuator button is fully depressed and is locked flush with the applicator surface. Remove the needle in the same direction as used to enter the vitreous.
Yeah, the thing is they have not removed the needle in the same direction they entered the vitreous. That's the only fault in the video. You should actually make a biplanar incision. Like while you're entering, you'll be entering parallel to the surface of the sclera and then go perpendicular to the surface while injecting, and coming also, you'll be coming out in the same fashion. And after the procedure is over, we usually do an indirect ophthalmoscopy. First, we do light perception. The patient light perception should be visible. That's because that's immediately, easily, you can just ask a question and you can know that, right? Okay, that's how it's going to be helpful. So immediately after the procedure, we'll do an indirect ophthalmoscopy to look for the position of the drug and also to ascertain anybody? Pawan was telling just now, pulsations, disc pulsation, okay, to know whether there is inadvertent rays of IOP and that can cause CRAO, okay? Yes. We'll talk about the advantages. So especially with respect to uveitis synthesis, there are studies which suggest that it will improve the visual acuity by 1 month, 0.15 logmer. By third month, it will be 0.22 logmer. And by 6th month after the injection, after one first injection, 0.24. That comes to almost 612 when compared to Snellen's visual acuity. And central macular thickness reduction when compared to baseline thickness was 344. By 1 month, there was 179 microns reduction. And by third month, it was 223 microns reduction. But by the 6th month, it was only 140 from the baseline. Means there was little increase, paradoxical increase in the central macular thickness at the 6th month after injection. And there's a Huron study that says that if the baseline vitreous haze was 2+, there was 47% reduction of vitreous haze at the end of 8th week. And for the people who had 3+ or 4+ vit haze, there was 40% reduction to 0 vit haze level post-injection. And one more advantage is there is also reduction of subretinal gliosis following Ozurdex injection. So we'll talk about the adverse effects that can be drug related. It can cause up to 13 to 20% raise in IOP post injection, and the progression of cataract in up to 5.4% of the eyes, phakic eyes. And there can be immediately subconjunctival hemorrhage and can be minimal pain can be there because of the procedure. So what can go wrong? So as sir was telling, you should take an informed consent, know what is the right indication, because if in a case of ARN, injection of local steroids is absolutely contraindicated. So something like that, knowing the indication properly and examining the patient in a proper way before you advise the procedure is very important. So if the patient is either a pseudophakic or an aphakic, when you inject in such patients, there can be anterior migration of the drug. Or in the pseudophakic patient with or either zonular insufficiency, or in aphakic patient, that anterior migration can look like a hypopyon-like appearance. And it can also cause localized corneal damage. Okay, there are people who are, their cases reports where they have confused it for a post-procedure endophthalmitis, and they have done vitrectomy, and only then when they enter the eyeball, they got to know it is not the hypopyon, it's a pseudo-hypopyon caused by the anterior migration of the Ozurdex implant in the AC. If there is such a migration, if that is not causing an inflammation, it's still okay, it can be absorbed. If that is causing corneal damage, that is an indication for the removal. You can just do a AC paracentesis, like the way we do a side port, just do a side port, and you can just remove the needle from the anterior chamber itself with a forceps. So asking history of chickenpox is very important. So there is a case of acute retinal necrosis following Ozurdex injection. So the patient had a history of chickenpox in childhood, which was usually we tend to not ask for this history. It is very important to know because the dormant virus will stay in the trigeminal neuron, and that can cause reactivation because of local immunosuppression after the drug injection. Strictly adhering to aseptic precautions with, as my friend was talking about, minimum 30 seconds of exposure to betadine is very important. If that is not properly being followed, it can cause endophthalmitis and that needs again intravitreal injections, intravitreal antibiotic injections, need for vitrectomy and removal of the implant. If the wrong site in the sense, like if the ideal measurements is like 3 mm in aphakic is not an indication. First of all, 3.5 mm pseudophakic and 4 mm in phakic patients. If that distance is not maintained, for example, if you are injecting the drug too close from the limbus, the implant can go and get lodged in the crystalline lens. So this is how it appears. And if such a thing happens, the ideal management would be to remove the lens with the implant, doing a cataract surgery. Or with if the distance is more than 4 mm, it can cause other than injecting in through the pars plana route, you are injecting directly into the retina. That can cause implantation of the implant onto the retina. Or if there is no retinal detachment, you can do laser around the implant, as done in this case. Or if there is a retinal detachment that needs immediate RD surgery, and there can be cases of vitreous hemorrhage also. They have even calculated the amount of pressure that with the force with which the implant goes in. They say it is up to 0.02 Newton meter. So if the force that is a little more in the vitrectomized eyes, but the amount of force that is need to cause vitreous hemorrhage is thought to be 0.2 Newton meters, but it is going at the speed of 0.02 to 0.05, which is much lesser than the actual amount of force that is needed to cause a vitreous hemorrhage or retinal detachment. So wrong technique, as I was telling during the procedure, you should maintain that biplanar incision and inject properly, slowly, and you should hear the audible click, and we'll do an examination to see the site of the implant. If you click it and just come back, even before confirming the device whether the implant has gone in, it can get lodged in the sclera. This is one of such a example. And if you're not properly maintaining the biplanar incision, the scleral entry point might not get closed. That can cause persistent wound leak and hypotony. So very rarely there is a paramacular hole caused because of forceful injection of the drug. So that's it from the presentation of Ozuldex. And thank you, everyone. And with this, I'll also like to pay my tribute to our beloved NAM sir. Thank you.